So, Bola, welcome to Stronger Things. It's an absolute pleasure to have you here.
Thank you so much. It's great to be here. Thanks for having me.
And I wonder if, just by way of introduction, your story and your motivation and your role are all equally inspirational. I'm wondering if you'd be happy just to share some of that with us today, just to kick us off.
So it's a great pleasure to be here. I'm Bola Owolabi. I'm a GP in the northeast of Derbyshire, in one of our ex-mining villages that I think represents the essence of the work that we do in trying to reduce health inequalities. In addition to that, I also work in NHS England as director for the National Healthcare Inequalities Improvement Program. And I think for me, it's the people that I see at my surgery, week in, week out, that inspire the work that we do. Whilst I appreciate the importance and the power of data and policy and strategy, ultimately, I do think the work we're trying to do is really about people and their lives and what it means to find yourself at the margins of society, what it looks like to live at the peripheries. That's what I care about. That's what drives me. And I'm blessed with an incredibly committed team that genuinely also care about these things.
Thank you so much, Bola. I think we all know that the world around us at the moment can feel quite challenging, and I know that very much the theme of Stronger Things this year is making it happen. One of the things that has always really struck me about your work and coming across you is your positivity and your optimism and your hope. And I think that's incredibly powerful for an audience like ourselves and for wider society. I wonder if you'd be able to talk us through some of the things that drive that hope. For example, your work with Core 20+5 and really shaping a way that we can respond to health inequalities.
Thank you, Claire. I think, you're right, that often the conversation around health inequalities ends up being a very deficit conversation about everything that is wrong. But that's not what energizes people. People are energized by a sense of hope and possibilities. And so we try and talk about the work we all need to do in reducing health inequalities from that strength-based position. And I've said many times before, and I'll say it again, that we should embrace our agency to act. Every individual has agency to act, whether in our own personal lives or in our professional lives. When I'm talking to my GP colleagues, I talk about the fact that we can do something in that individual patient-to-patient interaction. We can do something at the primary care network. We can do something in our own local system around influencing policy. Every one of us has agency, and so Core 20+5 is not the ultimate solution to health inequalities. It's a place to start. Because one of the things people said to me when I started in this role was the fact that health inequalities are not new, and this is not the first time that anyone has tried to make inroads in it. And so the point of Core 20+5 is about agency. It's about giving us focus on a handful of things so that we can gain some traction, and in that way be able to demonstrate impact within a reasonable time frame. And so for those who may not be familiar with Core 20+5, it's a mechanism for our 42 integrated care systems to know where to start. Which population group can we focus on first? And which clinical conditions contribute the most to the life expectancy gap? And so the Core 20 are the 20% most socioeconomically deprived communities by the index of multiple deprivation. The plus, they're the people who will still be lost from the data and who we know from our own local knowledge and insight, people experiencing homelessness, some of our coastal communities, some of our asylum seekers and refugees, for example, those in the criminal justice system, traveler communities, gypsy Roma communities, they are the plus. And the idea is each of our 42 ICSs know who their core 20 plus are, and then drive relentlessly after those 5 clinical areas of cardiovascular disease, of chronic respiratory disease, of cancer, maternity, mental health, and across all of that, smoking cessation. It's a healthcare inequalities improvement mechanism. And actually, it's the contribution of the NHS. It's not the sum total of what we need to do. I describe it as the NHS contribution to our wider effort with local authority and voluntary sector partners.
Thank you so much, Bola. And I think that message around agency is incredibly powerful and so relevant to the Stronger Things message. And I think there's a real resonance there. And I know you've started to talk there about the role of wider communities in working in partnership with the NHS. I wonder if you would be able to elaborate around, for example, the Community Connectors programme as a way that you've taken forward some of that thinking really explicitly to reach some of those communities.
Sure, thank you. I've often described the role of the NHS in tackling health inequalities across 4 domains. And one of them is being an active partner with other colleagues and partners within the integrated care system, particularly our local authority partners, the voluntary sector, our communities themselves. And one of my reflections from the pandemic is the power of the voice of community. I remember conversations with Pastor Agu of Jesus House here in London, when we were really struggling to get the community to the vaccines to the edges. Conversations with imams and some of the leaders of Gurdwaras. And they were the ones who said, people may be petrified of the virus. They may be petrified of leaving their homes, but they will go to their places of worship. If you can put the vaccines in places of worship, they'll come. And the lesson I learned from that is that there are insights about what will work in our communities that I will never know as a GP. I will only ever get to that insight by respectfully talking to the people on the ground. I've often said, and I'll say it again, that the other thing I learned is that the messenger is just as important as the message. For as long as it was healthcare professionals and professionals of other descriptions, people had their reticence. But when people who looked like them, sounded like them, began to say these messages, it cut through in a way that I could never have done. And that's why we've recruited and are recruiting a cadre of Core 20 Plus connectors. They are people from the community, of the community, the trusted people who can explain the why in a way that makes sense to their communities and cut through the jargon that sometimes we still end up using despite our best efforts not to. So that's who they are.
Thank you so much, Bola. I think that's a message that will really resonate with an audience that has already been dipped in community power this morning and that comes to this room with a strong sense of the power and the ability for us to achieve change and improvement as a community. I wonder whether you've also had some reflections on the role of local authorities in that broader kind of place-based approach to health inequalities.
Absolutely. I make it my business to go around the country because I was saying to Claire before we came on stage that everyone who joins my team, we tell ourselves we don't have coat hangers because health inequalities don't happen within our plush offices. They happen out in the community, and that's where we try to locate ourselves. And in going around the country, fantastic examples. In Newcastle, you have HealthWorks, who work with the local authority in Newcastle, with the local NHS trusts. They are a charitable organization. And I was with them looking at the work they're doing in terms of cardiac rehab for people who've had a heart attack, the work that they're doing to support people with diabetes to be ready for their elective procedure, the work they were doing with the elderly to try and reduce the incidence of falls. It's a joint local authority NHS VCSE partnership. In Bradford, I saw the doulas. These doulas, they are volunteers from the community, and they support women, typically women from very vulnerable backgrounds. They will support them for up to 6 weeks before delivery, sometimes even during labor, if their culture means their husbands can't be there or their partners. The doulas will be there in labor, and they will be there for 6 weeks after. They're volunteers. They're not healthcare professionals, but making a powerful difference. Another collaboration between the local authority and the NHS. In North and Mid-Essex NHS Trust, for example, again, I saw the NHS working with local authorities in Clacton-on-Sea, where they're supporting people from the 6th form college to gain apprenticeship and work placements. And that's where I met the wonderful Elliot, who described himself and said, Dr. Bola, I have global delay. I said, Elliot, I can't see it. You're running this dispensary amazingly well. And these are the examples I see all over the country where local authority colleagues with the NHS understand that not one of these organizations can on their own genuinely reduce the health inequalities that challenge our communities. The answer is between us. And I'm just giving you some examples of where practical demonstration of the answer being found between us.
Thank you, and it's really inspirational stories to hear. I think, and we were talking about this as well, that there's a real power in small actions, and there's also obviously a real power in scaling and large actions. And I wonder if we could have your thoughts on how you think we collectively as a community can start to work together to scale some of these innovations and to support those who are already innovating to take that even further.
So I think going back to my earlier comments around, embracing our agency to act, if we start from an individual level, I often say that conversation, purposeful conversation, is the most powerful tool for change. Maybe there is a conversation you could have after this conference. Maybe there is an email you could send. Maybe there is a colleague that maybe things haven't quite worked out between local authority and the NHS. Let's try again. And just understand that actually we are all trying to achieve the same thing. Sometimes it's our language that holds us back, sometimes our drivers, sometimes our constraints. But maybe we can go and have those conversations on the basis of we're all trying to do the right thing. So that's one thing that we can all do. The second thing we can do is let's get out there. There is enormous, wonderful work that people are doing with very little. I am amazed by how much people do with very little money. It's extraordinary. Let's not assume that until we have the millions, we can't make transformational change. I think if we commit to get out there, we'll see lots of wonderful things. And once we see them, let's not reinvent the wheel. I think there's a danger of it wasn't made here syndrome, where we try and start all over again. Let's celebrate that which is working, and let's build from strength, but do so with our communities. I'll just leave a note of warning about not trying to lift and shift. It's really important to work with our communities to contextualize things, to make sure that it's relevant and that it would work for them. I think those three things, we can all start there.
So I think that's our action list from today, is to take those things forward. And again, Bola, brilliantly human and practical things that we can all do. I think we have time for one more quick question. And one of the things I think would be lovely to end on is just to give you the space to talk a bit about your vision, so the vision that drives your work. And if you like, what you think success, if you like, would look like in 5 years' time. Because one of the challenges with tackling something as complex as health inequalities is that obviously the actions we take today will have an impact that we may not see for another 2 to 3 years. And I think that commitment and belief and long-term vision is a really important part of the motivation that we all need to bring to this. So if we could end just on your vision for 5 years.
So the vision, I think, has its power in the fact that it was crafted through the voices of many people. When I started in my role, I spent the first 6 months, 7 a.m. till 7 p.m., literally, every day, just talking to individuals, organizations, teams right across the country. What should we do? And what people said to me was, don't boil the ocean. If you try and do it all, you'll end up doing nothing. And so the vision that we came up with is exceptional quality healthcare for all, underscoring for all, and being mindful of 3 dimensions: that people have equitable access. It's not about equality, because equality assumes the same starting point, and that's not true. Equitable access. And once people cross the threshold, that they have an excellent experience, and that the combination of equitable access and excellent experience is what gets us to the optimal outcomes that I believe unites us. That is the vision. And how will we know in 5 years? 2 things. What the community says. I've often said that stories, people's stories, are data with soul. And whilst we do need to count the numbers, I think the stories that our communities tell in 5 years is probably the most powerful measure of success. And alongside that is that we have data that measurably, demonstrably shows the narrowing of the gap. So I think it's people's stories combined with our data that will tell us whether we've been true to the vision of leaving a powerful legacy beyond the pandemic, of narrowing the gap.
Thank you so much, Bola.